moving towards our fourth session, that is the Fantastic Four, is a combination of 4 medicines used to treat heart failure with reduced ejection fraction. To focus on this topic, we have our next 2 speakers with us. The first one, Dr. Narayan Bhattacharya, an eminent interventional cardiologist formerly attached with Command Hospital, Kolkata. And second, Dr. Somnath Mukhopadhyay, a renowned interventional cardiologist attached to various hospitals in Kolkata. And to chair this particular topic, I would like to invite Professor Dr. Shantanu Guho, a highly esteemed interventional cardiologist, former HOD, Department of Cardiology, Calcutta Medical College. So I'd like to request the chairperson, sir, to please come over the dais and introduce our speaker.
So without wasting any time, let us first discuss the topics. First speaker is Dr. Narayan Bhattacharya. He will be speaking on experience in clinical cardiology practice. So the subject is to go with the guidelines in heart failure patients using the Fantastic Four. Let us hear first from Dr. Narayan Bhattacharya. Dr. Narayan Bhattacharya, please.
So, with a heavy heart, good morning to everybody. And thank you, sir. Thank you for your kind words. And thank you, Howrah Diabetes, for having me here. Sir, how much time is allotted? How much time?
15 minutes around.
Huh?
15 to 20 minutes
15?
around.
Oh. So, e jeno mukur tole brahmandet chaya osimere tene ana simar majare. Heart failure within 15 minutes. So, as we all know that WHO predicted by 2020, India will be the hypertensive and diabetic capital of the world with maximum mortality and morbidity. But they missed one thing, that is heart failure. And heart failure is in limelight for last 1 decade almost. We all know that paradigm HF trial and heart failure. So there was one famous movie, Gone with the Wind. And now our topic will be go with the guidelines in heart failure using the Fantastic Four. So it is, we will go through heart failure scenario, evidence on current topics for heart failure management. So who is at increased risk of mortality? It is cancer patient or patient with heart failure. We will see. The actual burden of heart failure is way higher than projected burden. In our country, the statistics is very poor. The reporting system is very poor. So whatever we are seeing, heart failure cases in our country, it is almost 1 to 2% of total adult population. So it is almost 1 to 2 crore in our country. But it may be the tip of the iceberg, because the actual number is increasing very fast, and we can see the difference between the projected new heart failure cases by 2040 and the recent trend. So it is very alarming. The incidence of heart failure is soaring in India, but it may be underestimated. India witnesses a huge heart failure hospitalization burden, hospital burden at 1 year. We can see here that it is almost 30.2%, 1 year hospital readmission, and readmitted once, that is 24.4%, and readmitted more than once, it is 5.8%, though there is similar incidence between men and women. It is almost 30.3% for men and 30.9% for women. Similar incidence for HFrEF and HFpEF. It is for HFrEF, it is 30.1%, and for HFpEF, it is 31.6%. And increasing mortality in heart failure patient across the heart failure spectrum in India, It is almost 1/3 heart failure patients die within 1 year during their productive life years. Mortality rate per 1,100 person years of follow-up, it is HFrEF, it is 43.8%, and for HFpEF, it is 35.7%. And in India, the mortality rate in HFrEF patient increases with time. In hospital mortality almost 10%, 30-day mortality almost 14%, 90 days it is almost 20%, and 1 year it is 32%, 2 year it is 42%, 3 years it is 46%, and 5 year it is more than 50%. And one of the most important factor is lack of GDMT, which is associated with higher risk of mortality in Indian heart failure patients. Optimal GDMT can cause decrease in mortality for heart failure patient. We can see here the gap between the two curves. One is GDMT, guideline-directed medical therapy, and one is suboptimal. So it is a huge difference. And lack of GDMT is associated with higher risk of hospitalization and ED visits also. Here we can see that all-cause hospitalization, it is almost 29% greater. P-value was significant, less than 0.0001, and for CV-related hospitalization also, it is 21% increased risk for P-value was 0.00, less than 0.0079, and for ED visits also, it is 26% greater, that is P-value was 0.0001. So HFrEF patients not on GDMT present with 29% higher risk for all-cause hospitalization, 21% higher risk for CV-related hospitalization, and 26% higher risk for ED visits. Initiation and continuing GDMT keeps real-world HFrEF patients alive and live longer with quality of life also. So here we can see the curve that patients not on GDMT cohort had 29% increased risk of mortality compared to patients on GDMT. Guideline-directed medical therapy, it can be given at different points, that is multiple potential time points for referral. It may be ambulatory care, it may be urgent care, it may be emergency department visit, it may be hospitalization. So key goal should be up titration to target doses and introduction of newer therapies and evidence-based approaches to comorbidities. GDMT is the foundation of heart failure care, and GDMT with the highest expected benefit should be prioritized. What is the current available therapies for heart failure? In fact, I have already told that last 1 decade, heart failure has been given much more importance, because we can see here that in 2013, there are 3 main pillars of heart failure therapy, mainly ACE inhibitor or ARB, beta blocker, and MRA. But after paradigm HF trial, we all know that was one of the biggest trial for heart failure, and it was worldwide. India also participated in a big way. And after that paradigm HF trial, there is a paradigm shift in management of heart failure patient. So after paradigm HF, we can see that primary composite change, 20% reduction. CV death, it was 20% reduction. And for heart failure hospitalization, it was 21% reduction. So shock valve keeps HFrEF patients out of hospital, helps them live longer. And change in guidelines also we can see after decades that 2016 ESC guideline for the diagnosis and treatment of acute and chronic heart failure, we can see here that ARDNI was given class 1 recommendation and level B recommendation in place of ACE inhibitor or ARB. Here we can see that angiotensin receptor, they can replace ACE inhibitor or ARB and with good result. And at the same time, ACC, AHA and HFSA, they also focused in 2016 in the same way. So it is usually that European and American guidelines are not always of similar opinion, but for heart failure management, their opinion was similar, and 2016, ACC, AHA and HFSA, they recommended ARNI as class 1 level B recommendation for heart failure management. So now in 2023, there are 4 main pillars of heart failure therapy: ARNI, beta blocker, MRA and SGLT2. And these 4 are called Fantastic 4. So while there has been considerable success in the past 2 decades in developing heart failure therapies, there remain significant unmet needs for improvement, implementation, and to address the substantial residual risk. Priorities and strategies for simultaneous focus on implementation and innovation are there, and gradually the residual risk gap is reducing, and we must focus on implementation that should be simultaneous with incremental and continued innovation and discovery since to reduce the residual risk. Drugs that reduce mortality in heart failure. We can see here ARNI, MRA, beta blocker, SGLT2, ACE inhibitor and ARB. The meta-analysis shows the hierarchy of benefit in relative risk reduction, with the first 4 categories being the Fantastic 4. With ARNI it is 25%, with MRA it is 24%, with the beta blocker it is 22%, and with SGLT2 inhibitor it is 12%. So these 4 are called Fantastic 4. And it was huge trial, 75 trials, and the total number of patients were 95,444. So to summarize, heart failure is a new malignancy, as 5-year survival rate in heart failure is worse than cancers such as breast cancer, prostate cancer, or colon cancer. Lack of GDMT was associated with higher risk of hospitalization, ED visits and mortality. GDMT is the foundation of heart failure care, and GDMT with the highest expected benefit should be prioritized, and focus on implementation should be simultaneous with the incremental to continued innovation. So thank you. Over to Somnath.
Thank you.
I am on time. Time ঠিক আছে স্যার?
হ্যাঁ, টাইম একদম ঠিক আছে। Please sit here. Take a seat here. Now requesting Dr. Somnath Mukhopadhyay to give his lecture.
Good morning, respected chairperson and my respected colleagues. So we have realized the burden of heart failure in Indian scenario, and we have recognized our armamentarium to treat the heart failure situation with the newer drugs in our armamentarium. There are lots of newer drugs as well. So without wasting the time, we are going to the topic proper, which is guideline recommendation and challenges in optimizing GDMT using the 4 pillars of heart failure management. It is nowadays in our situation, in today's situation, it is nowadays new malignancy, as Dr. Narayan Bhattacharya aptly told. Guidelines recommended the use of Fantastic 4 for the spectrum of heart failure patient. If we see the recommendation by the initial guidelines, ARNI, that means the overall RAS blockers, especially ARNI, beta blocker, mineralocorticoid receptor antagonist, and SGLT2 inhibitors, all are recommended as class 1 in heart failure with reduced ejection fraction. And in heart failure with mildly reduced ejection fraction and preserved ejection fraction, these were class 2B recommendations. But nowadays, since ESC 2023 guideline, the recommendation has been changed for SGLT2 inhibitor in heart failure with mildly reduced ejection fraction and HFrEF. In both the situation, it is class 1 recommendation nowadays, and the other drugs like ARNI, AC inhibitor, ARB, beta blocker, MRA, all are class 2B recommendation in those scenarios with MREF and HFrEF situation. But in HFrEF situation, all are class 1 indications. Now, in GDMT propagation, why is there clinical inertia in achieving optimum GDMT? So there are few things for physician's perspective, physician's inertia, that heart failure patient is often taken as stable patient, so no up titration is needed, or new drugs are needed for the treatment, no new drugs are needed. It is okay, the heart failure patients are doing good with our available treatment, so continue our available treatment, not going towards the up titration. Second thing is GDMT is not titrated to optimum dose, and minimal initiation, in-hospital initiation is very minimal. That we often scared that whether this drug, side effect of this drug can can harm the patient during hospital stay. And apart from the physician's inertia, there are lots of things like cost of therapy is very high for physician, and the pill burden is also high. Patients' reluctance to take so many pills with heart failure management. Nowadays, in hypertension management also, we can see single pill combination with hypertension management, but there is no single pill combination concept in heart failure till date. And the other thing is, apart from this, cost of therapy is very important for patient perspective and Indian perspective. So the initial part is stability is an illusion in heart failure situation. Persistent heart failure is there. Heart failure is not a stable thing. It is a perpetuating thing. No such thing is called as truly stable heart failure. Heart failure is always progressive. And even when a stable patient does not show overt sign of progression, the biomarker levels like NT-proBNP may be raised. When medications are prescribed, most receive low or sub-target dose. And in fact, 1% only receive triple therapy. Triple therapy means our RAS blockers, MRA, and beta blockers. Minimal initiation is there and titration is there during hospitalization. Percentage of eligibility patient with HFrEF not receiving GDMT at discharge, if we see AC inhibitor ARB ARNI is only 32%, beta blocker is 25%, and mineralocorticoid receptor antagonist is 50%. It is very worrisome to have such data that in hospital, during hospital stay, when the patient is stable, we are not initiating or up titrating our current GDMTs. But we know the benefit of GDMT appears within days, 2 weeks. If we see the CBIS-2 trial with bisoprolol, the trial was for 1.3 years, and the benefit is very, initially we got the benefit with the bisoprolol. And if we see Copernicus trial with carvedilol, the benefit is from 4 weeks, the benefit is there. Similar thing is there with SGLT2 inhibitor dapagliflozin in the various trials. In MRA, if we see emphasis heart failure trial with MRA, epridinone, the benefit is there from 30 days. And again, it is for ARNI also in pioneer heart failure trial, though it is in acute heart failure setting. In pioneer heart failure trial is also the CV death or heart failure rehospitalization improvement, significant clinical benefit is there. It is starting from 30 days only. So initial mortality, the most mortality happens within 30 days of heart failure. Any acute decompensated heart failure after hospital stay, after stabilizing the patient, in mortality it is very much high within 30 days. So reducing mortality within 30 days is a primary target for us. So it is always better to have GDMT initially during hospital stay after stabilizing the patient. Guideline recommendation in using 4 pillars of heart failure management, their ESC guideline is telling nowadays an intensive strategy of initiation and rapid up titration of evidence-based treatment before discharge and during frequent and careful follow-up visit in the first 6 weeks following a heart failure hospitalization is recommended to reduce the risk of heart failure rehospitalization or death. This intensive strategy also applies for worsening heart failure situation. Nowadays, worsening heart failure terminology appears after a new molecule named vericiguat for heart failure, and it is in a Victoria trial. This worsening heart failure terminology got popularity, but worsening heart failure is there since the paradigm heart failure trial as well. Now, new guideline focuses on adding drugs rapidly. Initially, we think that conventional sequencing first give AC inhibitor or ARB in low dose, then stepwise approach initiate beta blocker thereafter after 1 week or 2 weeks, then after that mineralocorticoid receptor antagonist, then if AC inhibitor ARB is not working properly, then switch over to ARNI, then add SGLT2 inhibitor. But nowadays the thing is not similar. Rapid sequencing, you can start beta blocker SGLT2 inhibitor initially after stabilizing, then you can go for adding ARNI, then again MRA can be added. These are the steps in the left hand side, this step 1, step 2 and step 3, rapid sequencing, and we can, all the 3 steps can be achieved within 4 weeks up titration to largest dose thereafter. This simultaneous or rapid sequencing initiation of quadruple medical therapy has benefit 42% change in CV death and heart failure hospitalization, 25% change in death. CV death or heart failure hospitalization combination is 37% change, and when we are combining CV death, heart failure hospitalization or emergency visit for worsening heart failure, then also around 60% change is there. These 4 pillars of GDMT, when we actually add all the 4 drugs, there are 4 drugs, 5 pathways, numerous benefits are there with reverse cardiac remodeling, improved quality of life, fewer hospitalization is there, fewer deaths are there. If we comprehensively add ARNI, beta blocker, MRA and SGLT2 inhibitor, then there is 62% relative risk reduction of CV death plus heart failure hospitalization. Mind that 62%, not a joke. There is 50% reduction in CV death if we combine these 3 drugs, and 68% reduction of heart failure hospitalization. And most important thing is 47% reduction in all-cause mortality as well. And there is 44% reduction in projected event-free survival at 55 years. Now, come to a trial recently published in 2022. There is a trial called Strong Heart Failure Trial. This strong heart failure trial gained popularity due to its rapid initiation of GDMT. They actually classified high intensity care group. It is around 1,000 population. The population N was 1,000. 500 patients are there in the high intensity care group where recommended GDMT has been given, 100% recommended GDMT has been given within 2 weeks in that population of 500, and other 500 they are having usual care which is prevailing at that point at that nation. It is multinational trial, open label trial, and they showed initially they showed there is significant reduction in heart rate, systolic blood pressure, peripheral edema. So hemodynamic improvement was there, as well as NYHA class improvement was there, and NT-proBNP level came down with high intensity care group. Now, actually the pre-specified time period of strong heart failure was 180 days. But after 90 days, they have seen the benefit. And that benefit is not associated with any serious adverse events or any fatal serious adverse event. Though there are some evidences of increased adverse event with high intensity care, like hypotension, like other hyperkalemia, but serious adverse events are not there with these drugs. There are primary and secondary endpoint reduction with strong heart failure trial. They have seen that the benefit is there with the guideline recommended therapy, but guideline directed therapy if initiated within 2 weeks with 100% targeted dose. Next is simultaneous or rapid sequencing initiation of quadruple medical therapy for heart failure, optimizing therapy with the need for speed. They have seen that again, same things are there. Start all 4 mortality reducing drug without delay or in rapid sequencing. That is the similar thing. And they are implementing this strong heart failure trial in clinical practice. In ESC guideline also, they are actually they are thinking to implement the rapid sequencing and already implemented this rapid sequencing as early as possible. And start patients on GDMT as soon as they are eligible. Rapid sequence follow-up protocol should be used. Interprofessional coordination may facilitate the care. Explore ways to monitor patient remotely. In-home phlebotomy for serial lab values can be done. Embracing these strategies can optimize patient care and prevent rehospitalization. So to summarize, guideline recommends an intensive strategy of initiation and rapid uptitration of evidence-based treatment before discharge and during frequent and careful follow-up visit in the first 6 weeks following a heart failure hospitalization. Risk reduction and expected lifetime benefits are superior with the 4 pillars of therapy in chronic HFrEF, and strong heart failure studies showed that intensive treatment strategy of rapid uptitration of GDMT and close follow-up after an acute heart failure admission after stabilization was readily accepted by patient because it reduced symptoms, improved quality of life, and reduced the risk of 180-day all-cause mortality or heart failure readmission compared with usual care, but the benefit starts from the 90 days only. Thank you.
Thank you, Somnath. Please take your seat here. I is open for any questions. Any question from the floor? Otherwise, let me set the ball rolling. I'll ask either of you, what do you consider the strongest hurdle to initiate the GDMT in patients with heart failure in your own practice?
Sir, one is financial burden, sir. I have to convince the patient. Otherwise, they usually tell, especially with originator molecule, not after that.
But nowadays the prices come down very significantly.
I am telling. And when you are using GDMT, it is four molecule. Totally, it is costly affair. But if you can convince them that it is much less costlier because you are comparing with ICU admission. Your ICU admission will be less.
So one is price. That is the problem in India every time. Any other hurdle you face?
Otherwise, another is patient attendant and patient monitoring is sometimes a little bit difficult part.
Somnath, you want to add something?
I think for most of us, hypotension, initial part, that is the most important thing.
Tolerance. Patient's tolerance is a real problem in our country because as per the guidelines, you need to give it, say, ARNI, 200 milligram twice daily. How many of your patients can tolerate that? We cannot start even with 50 milligram as directed. The blood pressure remains in and around 100. We split the tablet, make it half and give 25. We initiate 25 milligram twice daily, which is not mentioned in any guideline. It is our own innovation. But that too, with 25 milligram twice, the blood pressure often comes down to around 80-85. What to do then?
Sir, for me, if 25 milligram twice daily dose has been given and the patient is not so much symptomatic, then systolic blood pressure around 90 perhaps accepted if the peripheral perfusion or urine output is good enough. But if the patient is complaining that I am having symptoms of hypotension, lightheadedness, or patient's urine output is decreasing, or any other events that systolic blood pressure is going towards 80, cold coming extremities, so we have to switch over we have to stop the drug or to go for other drugs.
So that is one very important hurdle.
And another, sir, if patient is on diuretic or MRA, I can cut the diuretic part, I can de-escalate the diuretic part, even I can stop if the patient is euvolemic, and that can help a little bit. And if the patient is not symptomatic, if the pressure is low, I have so many patients, their pressure is 90/60, 90/50, but they are doing fine.
Actually, a blood pressure of systolic 90, if the urine output is adequate and if the patient is not having lightheadedness and other things, is not a problem.
Not a problem.
You can jolly well carry on. But another issue in this particular thing, often these patients receive nitrates and other drugs. These things can be stopped to raise the blood pressure a bit.
Sir, another thing actually, it is not as per GDMT, they are recommending after 4 weeks, we will increase the dose to double. I usually, sir, start 50 VD, then for 2 to 3 months, I continue this. And after 2 to 3 months, actually there is one stabilization. Because that heart part, it is improved. Heart failure part is improved and patient is feeling good. And after that, I escalate not as 100 BD. I give 150.
75. 75
Then
milligram, that is the
gradually and
usual
gradually
practice with everybody.
I increase.
True, absolutely correct.
Sir, another important thing I want to add that whenever the patient is admitted in hospital, then there is infection, perhaps infection is going on, perhaps inflammation is going on. So once in a point of time when the patient is stable, in next point of time the patient may become unstable, and suppose we are using beta blocker in that patient and optimizing the drug, optimizing the dose, patient may need dobutamine for next day only. So these are the situation, but dobutamine will not work properly if the patient is already on beta blocker. So these are the things, whenever the patient is hospitally admitted in a hospital, the patient is actually not stable. So after stabilizing the patient, it is always better to have GDMT up titration in after discharge. But we should initiate the GDMT if possible in hospital.
Yeah.
So my question is that the different categories of heart failure we are using this ARNI. So we have definite indication of ARNI in the use of heart failure with reduced ejection fraction. And the sequence of events will be definitely is rather different from the heart failure with reduced ejection fraction considering the ARNI. And what about the heart failure with the mid-range ejection fraction, and what about the heart rate and the heart failure with the preserved ejection fraction? What will be your sequence of this that is the ARNI use in heart failure reduced ejection fraction, heart failure with mid-range, and heart failure with preserved? Though there is no specific indication of using this ARNI in the heart failure with preserved ejection fraction. This is my first question. The second question regarding the MRA, because the recent study, particularly in the heart failure with preserved ejection fractions, the finerenone has come a long way. And along with this SGLT2 inhibitor in the HFrEF, what is your take on regarding the use of MRA in heart failure with preserved? What should be? Either we will go for this spironolactone and this eplerenone, or we can go for this ARI study has also come with the finerenone. So the first question, sequence of the ARNI in reduced, mid-range and preserved, and also the MRA, use of MRA in preserved.
Okay. So for your, I am taking the second question first. I am taking the second question first. In fine art trial, there is benefit is there, and if you see TopCat trial, then also there is ray of benefit, hope of benefit was there in TopCat trial with the initial part 2013 also. But fine art trial actually give the evidence of introducing this finerenone molecule in heart failure with preserved ejection fraction, and now we can see the this recommendation in our later guidelines. Perhaps it will come, and maybe there is benefit of this molecule in heart failure reduced ejection fraction as well. And your first question, ARNI in HFrEF and MREF. There is no question regarding HFrEF. In HFrEF and MREF, it is 2B indication. Sure. It can be used. Sir can add.
No, in the Paragon trial, in this particularly this ARNI, that very narrowly missed the reaching the primary endpoint. Yeah, it was very narrowly it missed it. So when in HFpEF, the primary thing is you need to tackle the underlying cause. Underlying cause needs to be tackled. Diuretics has been to be given to take care of the volume overload, and SGLT2 inhibitors has shown some benefit. MRA has shown some benefit right from TopCat to the fine art. So perhaps these drugs can be tried, but still now the recommendation is not for SGLT2, it is 2A, and others is 2B. So what we can do, a patient of hypertension or something who is having HFpEF, in place of ACE inhibitor or the ARB, we can switch over to ARNI, but there is again no such guideline. It is an extrapolation of the test results, trial results in clinical practice.
Just three specific questions. What is the evidence of using ARNI in patients with GFR less than 20? What is the evidence of having low dose ARNI in GFR less than 20? And if there is any study, what is the duration of the study?
In GFR less than 20, all the RAS blockers are difficult to continue unless and until the patient is receiving some renal replacement therapy. If a patient is on some renal replacement therapy, you can go ahead, but otherwise it becomes very difficult, particularly monitoring the potassium becomes extremely difficult in such patients. Sorry?
Sodium zirconium is
Still now there is no specific recommendation regarding that. So we shouldn't say about that, comment about that. And your second question was? Low dose ARNI we do give in other populations. I started this discussion by telling we initiate in majority of the patients with 25 milligram twice, not 50 milligrams. So that is going to also be beneficial because the excretion will be low, so that there will be some buildup of ARNI. But how safe it is, that is the question. It needs a very close supervision, otherwise creatinine and potassium, particularly potassium, will play havoc.
Sir, I have just one question.
Hey, they are telling
Sir,
to end it up. We will discuss it later.
last.
So, how to take care of these patients?
These patients are not in heart failure, as you are telling. Grade 1 diastolic dysfunction in all elderly persons you will find. So grade 1 diastolic dysfunction, NT-proBNP, if along with it NT-proBNP is high, I do have some evidence. If there is a clinical evidence, patient is breathless, is orthopneic or something, there is some evidence. But if these things are not there...
Clinical evidence is there, patient is feeling breathlessness.
No. Exertional breathlessness is different. There may be 101 causes for that. If there is an NT-proBNP elevation along with some structural heart disease, I will consider that thing as perhaps we are dealing with a case of heart failure. But otherwise, other circumstantial things and other coexisting diseases to be tackled first. Obesity needs to be tackled. Hypertension needs to be controlled. And so don't jump into the therapy of heart failure, because for HFpEF, we don't have any definitive therapy as we have for HFrEF. So for HFpEF, treat the underlying cause. That is the main say. I think we should end
so
up the
much.
session. Thank you very much.
Thank you, Speaker. Thank you, Chairperson. It's time to facilitate you all. I would like to request Dr. G.P. Bhattacharya to please facilitate our Speaker and Chairperson. Bismay Kumar, please join. And also Dr. Somnath Mukhopadhyay, sir.
Crystal clear, not fluid.
Thank you so much. Thank you, Speaker. Thank you, Chairperson.